Yes, it
Yes,
is.
yes.
Okay, great. So this is a talk I gave for Grand Rounds here a little earlier this year, and then also gave it in Vermont, the University of Vermont. I was invited to do a lecture there with someone I collaborate with. Really good points there, and probably at the time without treatment, maybe people didn't live long enough with Parkinson's to see the intellectual changes that we know now oftentimes do come. And I think in talking about this, it is good to talk about some definitions. So a disease is a deviation or disorder in normal function, resulting in specific symptoms, physiological abnormalities, or pathological changes. Disease classification is a systematic categorization based on various criteria. Disease staging is categorization and classification of the extent or progression of a particular disease. And then a rating scale is a standardized measurement instrument to quantify or measure aspects of health, symptoms, functioning, and disease severity. So just for an overview of what I'm going to go over, I'm going to talk about the current diagnostic classification of Parkinson's, and then review alpha-synuclein measurements, imaging tools in Parkinson's, genetics in Parkinson's, and then review the current staging systems, and then go over the two new classification systems that have been proposed, and then some commentary on the two systems. So reviewing the current diagnostic classification, the way that we currently diagnose Parkinson's is really looking at what we see physically at the symptoms of Parkinson's. So we suspect Parkinsonism because of slowness of movement, resting tremor, rigidity. We try to throw out things that might look like Parkinson's, with essential tremor being one of the most common things. And then we think, is it Parkinson's disease? And then we classify it as sporadic or genetic if we do genetic testing, or maybe have a strong family history. And we think of other causes of Parkinson's, and then break it down into atypical Parkinsonisms like multiple system atrophy or MSA, progressive supranuclear palsy, or PSP, cortical basal degeneration, or CBD, or dementia with Lewy bodies, DLB. And then we have other things such as vascular Parkinsonism, drug-induced Parkinsonism with neuroleptics, and some other less common things that we can see. But we really start with the symptoms and then kind of break it down from there. And what are the symptoms? So I talked about a few of these: stooped posture, back rigidity, mass facies, this tilting forward posture, reduced arm swing, this resting tremor often in the hands. You can also see tremors in the legs. Excuse me, we tend to see flexing at the elbows and wrists, as well as at the knees and hips, and then this short shuffling gait. But in addition to the physical symptoms of Parkinson's, there's a lot else that's involved with Parkinson's, a lot of things that people can't so obviously see. So constipation, speech changes, swallowing difficulty, panic attacks and anxiety issues, hyposmia or loss of smell, lack of facial expression, low blood pressure, hypotension, especially orthostatic hypotension, impulse control disorders, and sometimes delusional behaviors, sleep issues. We think especially about REM sleep behavior disorder, bladder issues, pain, depression, we said anxiety, reflux, hallucinations, sweating, dementia, erectile dysfunction. So there's all these other things going along in addition to those motor symptoms that we see. And one thing we'll often say in Parkinson's is that people with Parkinson's are like snowflakes. So you've seen one case of Parkinson's, you've seen one case of Parkinson's, that each person's a little bit unique. So one person might have really bad constipation and not any depression, and somebody else might have really bad anxiety and their bowels might be pretty good. So we know there's these things that can happen, but not everyone has those happen in the same degree or in the same combination. So everyone's a little bit different. So the diagnostic, the diagnostic criteria that we have currently have been based on clinical criteria. So diagnosing the disease has been based on clinical criteria, and there's a few of these that have come out through the years, the earliest being in 92, then one in 99, and one in 2015. And so one is the UK Brain Bank criteria, and these all kind of have a somewhat similar pattern of you step one, diagnose a Parkinsonian syndrome. We talked about what's needed here: slowness of movement, and then rigidity, tremor, and posture instability not accounted for by other things. And then there's some exclusion criteria to make sure that we're not looking at something other than Parkinson's. And then we've got some supportive criteria. So we pick out different numbers of these, and then that gives us our diagnosis potentially. And then this is a more recent one. It's a little bit more involved, but very similar idea of you have to have certain baseline things and then other things that would be exclusionary. And I kind of like the graphic representation, and you don't need to get all the details, but the green puts you more towards Parkinson's, the red puts you more towards atypical Parkinson's, and depending on where those scales fall, you get a diagnosis of idiopathic Parkinson's or something else. And then there are some supportive criteria in here. So they did start to bring in some imaging characteristics as well as the clinical, but these aren't required to make the diagnosis. So there was a supportive criteria of an abnormal MIBG scan, which I'll talk a little bit more about what that is. And then Rachel Larson is, I think I'm going to decline that. Hopefully that's okay. And then there's some red flags. So if someone has a normal DAT scan, and I'll again talk about what that is. So you don't have to do these imaging criteria to make the diagnosis, but they're now incorporating these potential tools to help in the diagnosis. And then another one is the Gelb criteria, and this is divided into possible, probable, and definite. And I think the big key here is that the definite is based on pathology, which in Parkinson's, we know we don't get pathology in the brain until someone's passed. So this is really not, you can't make a definite diagnosis for the vast majority of people during life unless they happen to have a brain biopsy for some other reason. And then this definite pathology is from seeing these Lewy bodies in certain parts of the brain, in the substantia nigra or in the locus coeruleus. And these are pictured here. And the Lewy bodies contain alpha-synuclein, which I'll talk a little bit more about. So how successful are these prior diagnostic criteria? It depends a lot on the study. It depends a lot on the criteria used. It depends on the stage in the disease. It also depends on who's making the diagnosis and using the criteria. In general, with older criteria, general neurologists were correct about 70% of the time, fairly early on. Movement disorders neurologists were correct about 90% of the time with the older criteria. And with the newer criteria, even in early stages, we can get up to about 84% for any clinician, and then about 91% for movement disorder specialists. So we're getting a little bit better. And this kind of shows what clinically is happening with people with Parkinson's. So we have this dopamine loss that's going on for many years before we see a diagnosis of Parkinson's. So when we get to about 50 to 60% loss is when we're going to think we're going to start to see symptoms. But these non-motor manifestations start sooner than that, and then continue to progress over time. And same with the motor will start at some point along here and then continue to progress over time. But there's many years here before we get to this point of seeing symptoms. And many people are very interested in trying to find people at these stages and hopefully intervene and have people do better with their Parkinson's over time. So now I want to talk a little bit about some different tools that we have that are newer. And one is alpha-synuclein measurements. So this was from April of 2023, this breaking news that a Parkinson's disease biomarker was found. This is something we've really been missing in Parkinson's. And this was using the PPMI study through Michael J. Fox, looking at alpha-synuclein and seed amplification. So they were able to take the alpha-synuclein and amplify it to where they could identify alpha-synuclein in cerebral spinal fluid. And what this is what we see in the fluid, and then this is what happens in the body, is that there's these monomers of alpha-synuclein that then become oligomers, then fibrils, then Lewy bodies, and then we see these collections within the neurons. What we can do now with this new technology is that we can have this protein that's in the CSF, and then they're able to add these seeds to it, which then cause it to build up into these fibrils and then to alpha-synuclein aggregates. And we can now measure alpha-synuclein in CSF, which we didn't used to be able to do. So it allows for these minor amounts of alpha-synuclein to be expanded upon. And so now we can measure them when before the volume was just too low to be able to do that. So hopefully that makes some sense. There's two main ways that we do this nowadays. One is with a lumbar puncture and getting cerebral spinal fluid to look at. That's the most widely studied up to this point. And then there's also skin biopsies that can be done and used that way. So this is an example of a skin biopsy. A number of samples of skin, these small punch biopsies are taken from multiple places throughout the body, and then again can be measured, the alpha-synuclein. So this is really turning things upside down on its head. Again, there's going to be a lot of snow motifs, which isn't very appropriate for Thailand, but for Vermont, it was appropriate for that talk. So this is really turning things upside down on its head, right? Before we were talking about you have the clinical symptoms and that's kind of how you make the diagnosis. Now we're saying you're going to be testing for these things in people's CSF and skin that may be present even before we're seeing clear clinical Parkinson's disease. So next thing to review is the imaging tools in Parkinson's. So not quite as new technology, but still, fairly new. It was approved in 2011 in the FDA DAT scans. And this is the dopamine transporter scan, and it can give us an indication of what's going on in the basal ganglia with dopamine transport. And if we see this comma shape that you see in A, where there's kind of a red area up here and then another red area down below, this is a normal scan and what we would expect to see in somebody with essential tremor, somebody who doesn't have any sort of Parkinsonian disorder. This one over here, we see one that looks maybe a whisper of a comma, but then over on this other side, we really see it looks much more of a circle in the red. And so this is consistent with a Parkinsonian disorder, but this does not help us distinguish from idiopathic Parkinson's, multiple system atrophy, progressive supranuclear palsy. In all these cases, we would expect this test to be abnormal. And here is FDG PET. This can distinguish somewhat between the different types of Parkinsonian syndromes. It's not something that I think, the expertise around it varies a little bit. So I think it's not used clinically nearly as much. but it is another tool that can be used potentially to sometimes diagnose different Parkinsonian disorders and then also distinguish between them. It can be somewhat helpful. And then the last one I want to talk about was cardiac imaging. So these are SPECT MIBG scans. So these are images of the heart. And this can distinguish dementia with Lewy bodies and Parkinson's disease from disorders like multiple system atrophy and progressive supranuclear palsy. So we see abnormal scans in Parkinson's disease and dementia with Lewy bodies, but normal scans in MSA, PSP, or vascular Parkinsonism. There are some limitations to this. A lot of times in diabetics, we'll see abnormal scans because of the diabetes. So there can be other things that can interfere with this if there's autonomic neuropathy symptoms going on as well. Okay, this was a thing I liked that came out in June of 2023. This is by Michael Oken. He's at the University of Florida, and it was on I think the Parkinson's Foundation website. Do I need a skin biopsy or DAT scan for my Parkinson's disease? And basically the spoiler alert is if you already have a diagnosis of levodopa responsive Parkinson's, you probably don't require a skin biopsy or a DAT scan. These tools are really to help us when we're not quite sure of what's going on and to think about research-wise, can we identify people before they even go on to have clinical symptoms? These aren't really tools that we need. You know, we're pretty good when people are getting further along in Parkinson's and making the diagnosis, and we don't really need these tools at that point. Okay, so next going on to the genetics of Parkinson's. So this is an area where there's been, you know, loads of growth, loads of new studies coming out, new genes being found. Prior to 2005, that was the pre-GWAS era. So before we were doing these very, very large genetic studies, and we had quite a few genes found, but not a ton. And then in 2005, we see this much bigger progression of these larger GWAS studies coming out, 3, then 11, then 28, then 44, et cetera, and quite a few more genes that are involved in Parkinson's. And I'll show a little bit more about that. So we used to say, you know, unless you have a really strong family history, you're really young, there's probably not a big role of genetics. That's probably wrong. And it seems like now for up to 15% of patients, with Parkinson's, monogenic pathogenic variants predisposing to Parkinson's can be detected. So, you know, genes, as we learn more, we realize they're probably playing a fairly big role, but it's still a complicated role. So what we see in general is that we have these very common mutation, lots of them, and they probably increase risk by a little bit. And then we have kind of these moderately common like LRRK2, GBA, and they increase risk kind of medium. So definitely a clear increased risk, but just because you carry them doesn't mean you're going to get Parkinson's. And then we have these very rare genes where you have a very high risk of getting Parkinson's if you have these genes. So it kind of falls into different categories depending on the specific gene. And the more, the less frequent the gene is, usually the higher the risk, and then the more frequent is, the smaller the risk. So now going over the current staging system, which I could in some ways kind of skip this because we don't have a great staging system. But we do have this clinical scale, the Hoehn-Yahr scale, which, yes, that date's correct. 1967 is when the Hoehn-Yahr scale came out. And it's a pretty simple scale. Stage 1 is that one side of the body is affected by symptoms. Stage 2 is that both sides of the body are affected by Parkinson's symptoms. Stage 3 is that we see balance and stability becoming effective. And stage 4 is that symptoms increase and someone's still able to stand or walk, but has significant gait issues. And then stage 5 is that assistance is required for everyday activities. So pretty broad strokes here, and really just, again, clinical symptoms that we're looking at. So now getting on to the 2 new classification systems, which some people may find interesting, some may find it a bit dry. Hopefully it won't be too dry and bore you guys this morning. So these two systems came out, proposals in Lancet Neurology earlier in 2024, and they were published in the same what's the one? The same articles, the same edition. So one is called the Synergy Research Diagnostic Criteria, and then the other one is titled The Biological Definition of Neuronal Alpha-synuclein Disease Towards an Integrated Staging System for Research. And they were two different groups. The lower one here is a group that was really involved with the PPMI, project through Michael J. Fox. And it's basically the PPMI study group there that's on that. So I'll go through each of them a little bit with a deeper dive. So the first one, the Synergy, I think the name's definitely catchier than the other one. They really focus on a diagnostic criteria rather than a clinical staging system. The article is described as a personal view, and there's three components, plus the clinical component. And the three components include alpha-synuclein, and whether this is present or absent in tissue or CSF, and this is the SYN part of the Synergy. And then neurodegeneration, and this is defined by imaging, and that's the NEUR part. And then genes, and this is documentation of pathogenic genes, and this is GE. So altogether it comes to Synergy. And then there are clinical components, single high specificity clinical feature or multiple lower specificity clinical features that are also incorporated. So in looking at the SYN part, the alpha-synuclein, you either get SYN plus or SYN minus. And they endorse a couple of different methods of measuring alpha-synuclein. So we talked about the seed amplification, and they endorse both the CSF seed amplification as well as the skin. And then this is a slightly different one with immunohistochemistry or immunohistofluorescence in skin, and they do endorse that one as well. And then there's another number of tests that are investigational that for right now they don't support, but they feel like in time potentially they could do that. And then there are times when you'd be looking at other non idiopathic Parkinson's, and that's down here. I won't go into that in depth, but if they've got synuclein, it's going to be S positive, S negative if they do not. So then on to the next one is neurodegeneration, and they again have this big table where they go through a bunch of different means of measuring neurodegeneration, and then they talk about the ones that they support or endorse. So the dopaminergic PET or SPECT scan, the FDG PET, and then the cardiac study that we reviewed. And then there's some others that they don't endorse just yet, but again, feel like, in time, these may move into a different category. And then there's exclusion criteria. So you can rule out N positive with a structural MRI or with an FDG PET. So if you see characteristics typical of an atypical Parkinson's, like midbrain atrophy for PSP, then you could rule it out as an idiopathic Parkinson's, and same with the FDG PET if you saw a characteristic pattern there. Okay, and then the next part is the genetics, and for this they have a couple different subcategories. So it can be a G positive with a big F, and a big F means that it's a fully penetrant gene. So basically, if you carry this gene, there's a very high likelihood that you're going to get Parkinson's disease. Or it can be a lowercase p, a gene positive with the lowercase p. And this is a gene that gives you a strong predisposition, but isn't fully penetrant. So then they go through the different genes and where they like those. So SNCA is basically always fully penetrant. So these ones would be this capital F positive. And then they also say Parkin and Pink 1 and Pink 7 fall in this category. And then they get to these other ones that are going to be this lowercase p. And then if there was no genetic variant found, then it would be the G negative. Okay, and then they go through separately, there are these clinical features, and someone's either C positive or C probable. And this is based on how many of these different features they have. So a single cardinal manifestation of Parkinson's. Okay, someone wrote, what is the difference between fully penetrant and a strong disposition? So this means that you basically are going to get Parkinson's if you carry any of these genes, if you live till a normal age. These ones that are endorsed here, you have a stronger disposition, but not everyone is going to go on to get Parkinson's. So there's going to be a good chunk of people who carry these genes who are never going to get Parkinson's disease. And I don't know the numbers for each different gene off the top of my head, but I would say the ones they're picking as fully penetrant are in the 90 to 95, % category. I think LARC2 might be around like 70, 80%, but it's, less likely there. Yeah, having fully penetrant genes is worse. Exactly. Okay, so then looking at these features, so a single cardinal manifestation of Parkinson's or abnormal quantitative motor testing are the motor features that they would count. And then sensory features, autonomic features, sleep features, REM sleep behavior disorder is one of a very strong predisposing factor to having alpha-synuclein and then mild cognitive impairment. Okay, so then putting it all together, clinical features possibly related to Parkinson's disease. So you've got somebody who has possible Parkinson's. They've got one feature from one of the categories, and then they could be S positive or N positive. So they would have synuclein abnormality on a DAT scan, and or they could have sorry, that's wrong. A synuclein abnormality on a biopsy, either a skin biopsy or CSF test, or neurodegeneration on a DAT scan. Sorry, I said that backwards. And then one feature from one of the categories. And then option 2 that you could get to possible is one feature from 2 of the categories with a positive gene, and then you could have S negative and N negative. And then you would move on to C probable. There's a few different ways to get there. So it's not real clear. Neither of these systems are particularly easy, I think, to put into practice. And the idea is that these would be at a research level. And I think some of the key is to think about, okay, genes are playing a role, synuclein is playing a role, neurodegeneration is playing a role, and our clinical features are playing a role. And those are all important things to think about. Okay. And for each feature, it should be verified that there are no other more probable examination based on clinical judgment, and the temporal evolution of symptoms is consistent with Parkinson's disease. So if you had someone develop, urinary symptoms after a TERP that then didn't change for a decade and then developed a rest tremor, you wouldn't want to say that the urinary symptoms are probably because of the Parkinson. So, you want things to make sense. Okay, and then these are some examples where they kind of put it all together with different kinds of Parkinson's. So if you had somebody who had sporadic Parkinson's disease, you would expect them to be gene negative, that they would have abnormalities of synuclein. So if we did a CSF test on it, we would find synuclein, and that they would have neurodegeneration. And then that one skip because I'm confused on. And then there are some forms that look like Parkinson's disease that don't have synuclein. So we could see that, and that would be certain genetic forms that we see this. And let me see if I see which ones those. Yes. So this would be certain carriers are going to have what looks like Parkinson's disease has been called Parkinson's disease in the past, but they are not going to have synuclein. So there's some places where this doesn't quite fit. And then some people could have, if they were carried of genes that were very high penetrance, they would be GF positive even before they develop synuclein abnormalities or neurodegeneration. And that's part of the goal of these classifications, is to be able to identify people before they're going on to get actual clinical disease. Okay. So this is another way of looking at it, that if you had a genetic Parkinson's disease, you're gonna, whether it's a one that's going to be fully penetrant or predisposition, you're going to have these genes from forever. So that's going to be your status. That's what it's going to be. It's not going to change, or you could be genetically indeterminate. And then we would expect for most people, they're going to start out as synuclein negative, and then over time, we're going to see synuclein develop, and that's going to turn to positive. And then there's going to be these select cases of synuclein negative Parkinson's disease, which we're never going to see synuclein. And then neurodegeneration, we're going to see that develop over time as well. So we'd expect DAT scans to be normal, and then over time, we're going to see them convert to abnormal. And then clinical status, we're going to see that people don't have clinical signs of Parkinson's, and then over time, that's gonna happen. Okay. Oh, and they don't distinguish between prodromal and defined disease. And the clinical stuff it's not really where their focus is. It's really this making the pre-diagnosis for this one. Okay, so then moving on to the other system. So this is the NSD-ISS, Neuronal Alpha-synuclein Disease Integrated Staging System. This included a large working group and other stakeholders. And the goal really for the development of this was to help through therapeutic development, to be giving drugs prior to overt Parkinson's developing into testing medications. They lump Parkinson's disease and Lewy body dementia together, and this has diagnosis and staging. And they talk about biological anchors, which are alpha-synuclein, and dopaminergic system, which is kind of the same as the neurodegeneration system that the other classification used. And then they do have a scale for clinical signs and symptoms where they rank them from 0 to 6, and I'll go through that a little bit too. So the S anchor is the neuronal alpha-synuclein anchor, and people would be synuclein positive or negative. They only endorse the alpha-synuclein seed amplification of CSF. They don't endorse the skin biopsy at this point in theirs. And there are some research level alpha-synuclein tests that can distinguish multiple system atrophy from idiopathic Parkinson's. So that's specifically what they endorse. And then for the dopamine anchor, they refer to DAT scans, and that's the only one they say for that. But they do feel like more methods could come down in time. And they think that both anchors over time will become quantitative, so we'll be able to watch the change in synuclein over the time and watch the degree of dopaminergic dysfunction over time. And they think that additional anchors will be added over time. And then genetics, they look at this really separately, and it's not really part of their system. And there's times when they refer to it as a G for genetics, and other times as an R for risk in the paper. Its risk is either put as high or low based on the gene. So just like we were talking, the fully penetrant versus the not fully penetrant, they rate these as high and low risk genes. Okay. And then their staging is based on clinical symptoms, but also incorporates the biological anchors as well. Sorry, there's a little typo there. Symptoms and impairment could be motor or non-motor. So stage 0 would be that someone has no symptoms. Stage 1 would be that we see some of these pathological changes, so the alpha-synuclein and the dopamine transporter differences, but no actual signs or symptoms of Parkinson's or Lewy body dementia. And then stage 2 are subtle signs and symptoms, but no functional impairment. Stage 3 is slight functional impairment. Stage 4, mild functional impairment. Stage 5, moderate functional impairment. And then stage 6, severe functional impairment. And they don't go through and define these in detail. And that's not the intent of this part of it. It's really to just give kind of a broad system. And then the thought is that a lot of these details will be filled in time. So this is it in a graphical form. So you have, you start out with these genetic pieces of either a low risk or a high risk gene. And kind of, again, like the other system, you know, this is going to be the same no matter what. You're going to have it or you're not. It's not going to change over time, right? And then stage 0, the only people who would really fall on this at this time are these fully penetrant SNCA variants, where we know these people are going to go on to get Parkinson's. It's basically 100%. For anyone else, they wouldn't jump in until they're at stage 1A or stage 1B. And this is based on if they have alpha-synuclein or dopaminergic dysfunction, again, with that DAT scan. And then stage 2A and 2B are when they've got clinical signs and symptoms. And then stage 3 to 6, functional impairment. And it goes through, you know, gradually getting worse there. And so this is another way of kind of looking at what we would expect to be happening. So at stage 0, we would, you know, expect that people are going to be starting to develop some alpha-synuclein that's going to start to build up over time. And then we're going to start to see measures of alpha-synuclein that we can detect it when it kind of crosses this line. We're also going to expect to see a little later that we would see some dopaminergic neurodegeneration. And again, they're going to get to a threshold where we're going to start to see that can be measured. And then at some point, which we don't entirely understand where this is going to happen, it's a little bit more questionable. Someone will move from not having any symptoms to having some clinical signs. And then lastly, we'd expect to see functional impairment. And so the hope is, you know, that we could intervene at this point or at this point before someone's really developing functional impairment. But in order to be intervening at those stages, we've got to figure out how to identify people earlier on. Again, the staging, they are just really qualitative and conceptual. There's not an operational definition of these different, you know, 1, 2, 3, 4 really presented in the paper. And I don't think these exist yet. I think the thought was that these would be developed kind of down the road. So I'll wrap up with kind of a commentary on the 2 new systems. There's been a number of things published. This kind of goes through a comparison between the 2 systems. So Synergy is the one on the right, and the NSDISS is on the left. So both are looking at biological definitions. The NSDIS is less of a classification system. Synergy is more so. There's an integrated staging system within NSDIS that is not present in Synergy. They changed the label of the disease to an NSDIS. They're suggesting we call everything neuronal alpha-synuclein disease. Synergy is suggesting that we keep the name Parkinson's disease. And then for the rest of the components, it's basically that NSDIS is very particular, and they're not taking most things, you know, they're saying 1 form of seed amplification, 1 genetic variant to be considered fully penetrant, 1 type of scanning, and Synergy is a little bit more liberal about the tools that they think are reasonable to use. And then the clinical signs and symptoms are a little bit different between the 2. And again, not the focus of either one, really. So I won't go to that in a lot of depth. MDS came out with a statement on these classification systems, and they stated they perceive that there's a need for an international consensus in research aiming to classify Parkinson's with involvement of clinicians, basic science researchers, persons living with Parkinson's, and other stakeholders, including regulatory agencies and pharmaceutical companies. They have a concern with alpha-synuclein as a marker, that it's not a reliable way yet to know which clinical syndrome someone's going to develop, whether it's idiopathic Parkinson's or multiple system atrophy. There's no means to quantify it over time. There is this subset of patients with certain types of Parkinson's, especially some genetic forms that do not have alpha-synuclein. It doesn't reflect what's happening in the brain as of the way that the testing is done now. And again, most assays don't distinguish multiple system atrophy from Parkinson's. In terms of the staging system, they say there really isn't a current staging system, that Hone and Yar wouldn't really be defined as a staging system by today's criteria. It only reflects the motor, not the non-motor symptoms, and it doesn't cover preclinical phases. The landmarks that they proposed in the new staging system haven't been proved to be predictive of future disease progression or events. So it's really just a theoretical proposal and not something that has been tested. They recommend that any new system be studied and recommend an evidence-based consensus method be used to develop such a protocol, and that the new system should start just at a research level. And everyone agrees, I think, on this across the board. And then this was another commentary: has the time come to redefine Parkinson's disease? And they say, we welcome the new frameworks and find it an exciting research opportunity. Again, research keeps coming out here. Raise the question with the idea of labeling someone with a disease that does not have symptoms, especially concerns for people who carry genes that are not fully penetrant, so they may never develop disease. So I think Huntington's disease is one we think of, right? And how it's such a big deal to do testing, and we know that people are going to develop disease. Well, now, are we saying you should test for these things, but even if you test positive, there's a 60% chance you're going to get Parkinson's and a 40% you're not? What do you kind of do with that? And they feel like limiting it to just Parkinson's rather than lumping Parkinson's and Lewy body dementia together is preferable. And they worry about erroneous diagnoses with the synergy system, since they kind of have this lower bar for the components. They feel like the terms Parkinson's disease and Lewy body dementia should not be abandoned, that people are pretty connected to these terms and we should keep these. They have concerns over alpha-synuclein as a main part of the criteria because of its limits, concerns, and these are come up with multiple of the commentaries. Again, not all persons with Parkinson's or Lewy body dementia have alpha-synuclein. Postmortem studies have shown that with these seed amplifications, alpha-synuclein can be detected in persons without clinical symptoms of Parkinson's or Lewy body. So again, just like the genes, you're going to be at risk to go on, but what if you don't have it now? Is this an issue? There's not currently enough evidence to support a disease staging system. Risk of criteria being used prematurely in clinical settings, I think this is a big concern, and suggest that after more study, it will be appropriate to integrate the two criteria into one unified system. And then this was the last commentary that I looked at by Jose Obeso and Paolo Calabrese. And they had a little bit stronger wording that Parkinson's disease is a recognizable and useful diagnostic entity. They were concerned because they felt like clinical disease was really not at the forefront of these systems, that putting alpha-synuclein first will lead to more confusion, that many aspects of Parkinson's may not be related to alpha-synuclein, and these may be lost if we really jump towards this system and are looking at drug development just to approach alpha-synuclein. That lumping everyone together suggests that likely different disease processes are proceeding on a similar path. So they feel like maybe, what happens with the path is important as well, not just where does the path start. And then again, concerns about things moving from research to clinical practice prematurely. And then again, concerns with alpha-synuclein as a biomarker. They don't feel that it's validated enough, do not feel like there's enough evidence of reproducibility, do not feel it represents the sole origin or serves as a marker of progression of Parkinson's. They note that there are more than 100 other proteins seen in neuropathological inclusions and worry that we're just focusing on this one. And then that Parkinson's, Lewy body dementia, REM sleep behavior disorder involve damage in different parts of the brain, and just looking at alpha-synuclein doesn't really focus on this variable vulnerability. So their conclusion is that Parkinson's is a recognizable and valuable clinical pathological entity, that attempts to redefine are based on inadequate and partial assumptions, that unintended outcomes could come from incorrect assumptions. They rate these as academic endeavors. So even, I think, kind of give it a lower rating than the other ones. Feel the new systems will trigger discussion about disease mechanisms and therapeutics, and then do end with on a positive note that both proposals are highly welcome. So my kind of take on it, I would agree that Parkinson's disease is a recognizable and useful entity to the people here who we, I think, at least in the US, think of Parkinson's disease and put a face with the disease. So I agree that is an important component to keep up. I was also charged with putting in some DEI information for the talk I gave in Vermont. But I think this is interesting. Whenever we start to incorporate genetics, we really need to be careful about where our studies are coming from. And there's so many populations in the world that are often left out of genetic studies. So if genetics are going to be one of the starting points, we should really make a push to make sure we understand the genetics of Parkinson's across a lot of groups. Thankfully, there have been increases in this, and there's more genetic collaboration than there has been in the past. So we're doing better, but there's still quite a few places. This is based on publications, so it's not the ideal way, I think, in some ways to look at it, but definitely areas of the world where we're probably not doing as well getting genetic input. Okay, and then somebody, Cardozo, put in a paper, this opens up the possibility of creating a highly undesirable two-tiered diagnostic and staging system for Parkinson's, dictated by access to technology, limited by geography and expense. So I think a big concern here with how things could go moving forward and inequities. So my thoughts, it is appropriate to discuss these ideas and think about them. I think there's benefits of looking at genetics and pathological basis, especially for therapeutic targets, but I'm not sure that these systems will accomplish it. And I agree, kind of worried that we're targeting what we have and what we can measure when maybe there's so many other things going on that we're going to be missing. Worry that a lot of this is driven by this new tool. It's kind of what I just said. Knowing sooner has not proved to be helpful in some diseases. So for Huntington's, we've known for a while and we still haven't figured it out. Allowing someone to know they are at risk for something can be concerning, but also powerful. So I think in some ways that could be a positive thing. If you know you have a 70% risk of getting Parkinson's, are you going to be a little more apt to go to the gym 5 days a week and do the exercise that we know can be really helpful. And I think from a patient's perspective, symptoms are what matters. Greatest disability varies from patient to patient, and there is a risk of losing expertise or interest in symptom management, I think, sometimes if we're looking too much at this side of things. So that's the end of my talk, with sticking with the snowman motif. I have, I think, the smallest snowman ever built. This was a number of years ago by my young kiddos there. When we just had a dusting of snow. So that is the end. I'm happy to take any questions and answer them if I can. I definitely don't get all the nuances of the systems and occasionally get a little confused with some of them myself, but happy to take questions.